Greetings, welcome everybody to our Robert Wood Johnson Foundation Systems for Action Research Program Research in Progress webinar series. Hope everybody's having a good post 4th of July summer. We're glad to bring you another installment of our Research in Progress webinar, where we get a chance to share with you emerging research findings from the Systems for Action Research Program and talk a bit about what we're learning from these findings and how we can apply these findings to better align health and social systems and to achieve improvements in health and health equity. Today's session will feature, we're fortunate to have a group of different researchers who've been a part of the Systems for Action Research Program, and at least in one case, a part of the predecessor research program of Systems for Action. All of us sharing findings related to public health governance structures and what we are learning about the importance of those governance structures for achieving alignment across systems and for importantly achieving improvements in population health. So part of our, the members of our research panel today, their names are shown on the slide if you're with you on the web portion of today's webinar. They include Dr. Carl Letamendi. For those of you who have been part of our Systems for Action research family for the last several years, you will know and remember Carl. Carl was part of a research team that was funded a couple of years ago now by the Systems for Action research program. Back when Dr. Letamendi was with the New York City Department of Health. So Carl has some excellent background for studying issues around health and social services system alignment. He is currently with the state of Utah Department of Health, where he directs the Health Center for Health and Data Informatics there at the Department of Health. Prior to that, as I mentioned, he was at New York City Department of Health. Did some great work there and in New York City around both public health development and fostering collaboration between health and social service agencies. His PhD is trained in social sciences with an emphasis on conflict analysis and conflict resolution, very relevant skills when we're talking about system alignment. And has also worked in public health and health policy at the federal level, serving roles at NIH, as well as the U.S. Department of Agriculture in DC. So Carl will be a part of our panel today, partly reflecting on some findings from his work in New York City, studying local neighborhood level governance structures and their role in facilitating alignment between health and social services delivery. Also, part of our panel, I'll go ahead and introduce the second member of our panel today, Dr. Scott Hayes. Scott is currently Director of Research and Development with the Strategic Collaboration Group, which is a technical assistance and consulting organization that helps organizations figure out ways of forging better collaborative arrangements in their work. Prior to that, for a number of years, Scott worked at the University of Illinois in Urbana-Champaign and led health and social service research activities as part of that university. He's trained as a political scientist, and a lot of his research has focused specifically on governance structures in a variety of settings, including studies looking specifically at public health governance structures. Scott was actually a part of a funded research team that was that studied public health governance structures across the country as part of a study that was funded under the predecessor research program to Systems for Action, the Public Health Systems and Services Research Program of the Robert Wood Johnson Foundation that many of you may remember as well. Scott will be another part of our panels today. I'll be chiming in as a third panelist. Glen May's here at the University of Colorado in our Systems for Action program office. Be sharing with you some findings from our intramural research program related specifically to local public health governance structures and their role in facilitating multi-sector collaboration and improvements in health at the local level. So hopefully we've got a great group of panelists for you today. I want to share just quickly a little bit of our rationale for today's topic. Why focus on public health governance structures and what we can learn about those structures and how they may facilitate multi-sector collaboration and improvements in population health. Well, one reason for this topic kind of popping up on our radar is related to our experience over the past 18 months in responding to the COVID-19 pandemic here in the U.S. As many of you are I'm sure aware, public health agencies at both state and local levels have been thrust front and center into the response roles around responding to the pandemic around the country. In assuming those roles around the country, that those highly visible roles have generated both beneficial awareness about the functions of public health and in particular their legal powers and duties related to infectious disease control. These agencies have been front and center in formulating, enforcing, business closures and restrictions, mask mandates, testing and contact tracing, and now are front and center in rolling out vaccination efforts around the country. And that increased visibility and also I think the politicization of those roles around the country have generated some controversies. In particular, there have been efforts that have taken place around the country to weaken some of the legal authorities that public health agencies and by extension that public health governing boards have in the context of responding to pandemics and infectious disease outbreaks. Their ability to issue public health orders that restrict gatherings, that regulate businesses and business operations, that regulate personal behavior in terms of mask wearing, social distancing, and other protective factors. And there's actually been legislation proposed in more than 20 states now to actually preempt some of those legal authorities that are given to local public health governing boards and by extension to local public health agencies around the country because of disagreements with the legal ability of those agencies and those governing structures to carry out those types of regulatory activities. Here in Colorado, we've seen some of that legislation considered as well at the state level. We were actually quite fortunate in this legislative session in that the state legislature was successful in passing legislation actually to strengthen some of the capabilities of local public health governing boards and being able to carry out those kinds of protections. In particular, our new legislation here in Colorado generates new requirements for training of public health governing board members in carrying out their responsibilities around public health protection. That hasn't been the case in a number of other states around the country that have actually been successful in passing state laws that preempt local public health agency powers, regulatory powers around infectious disease control and pandemic response. So it's those political and legislative debates that have been playing out around the country, prompted us in Systems for Action to kind of take stock of what we've learned collectively through our research, around the roles of public health governance structures in facilitating effective public health practice, and also in facilitating progress toward multi-sector system alignment, a major focus of our program in S4A. So we're going to hear from several of our panelists today, the work that they've done in studying public health governance structures at various levels of geography and authority around the country. And we'll also have time for the end of the hour for just some open-ended discussion about both what we've learned about the importance of governance structures from research, and also what we may still need to learn from future research about the role of these governance structures in facilitating, again, multi-sector collaboration and ultimately facilitating progress toward health equity. So with that, I'm going to turn it over to our first panelist, Carl Letamendi, and for him to share some of his research with us.
Great, thanks so much, Dr. Mays. Let's go ahead and make sure that you all can see my presentation. Can I get a quick confirmation? Does that look all right?
Looks great, Carl.
All right, awesome. Well, good morning, everyone. Thanks for joining us today on this panel. My name is Carl Letamendi. I'm the Bureau Director for the Office of Healthcare Statistics at the Utah Department of Health. And this component of the panel is titled Reflecting on Committees and Boards for Advancing Public Health. And it's based on my experiences having worked at and in public health at the local, federal, and now at the state levels. And so as far as the outline is concerned, I'm going to start off with a couple of disclaimers, then I'll transition into talking about my experience at the local public health department level, which was in New York City. I'll talk about my project called PEACH, which was the RWJF Systems for Action funded project that we had, as well as cross collaboration at the local level and also community engagement in general. Then I'll talk about the governance councils, which were the premise of the research there in New York. And then I'll transition to talk about my experience now within the state health department, and also into committees that are less voluntary and community focused and more mandated by statute, and what that looks like and feels like, as well as the development of subcommittees and how we kind of went about that and why they exist. Then I'll talk about my experience at NIH of working on a specific initiative called the National Drug and Alcohol Facts Week, and how engagement looked like there and how I perceive engagement at the federal level. And then I'll summarize with a couple of takeaways based on my experience working across these three areas. Just a couple of disclaimers. The presentation that I'm delivering today doesn't represent the opinions or views of the Utah Department of Health, the New York City Department of Health, nor the National Institutes of Health. So I'm just here delivering this presentation as myself, having had experience working across these three public health entities. But just to share a little bit about my office and what currently happens now at the Office of Healthcare Statistics at the Utah Department of Health, we collect, analyze, and disseminate healthcare data and are responsible for several data series that a lot of you may be familiar with. The first is the Healthcare Facilities Database, which is all institutional patient encounters and discharges that occur across the state for qualifying licensed facilities. The second are the CAP surveys, the Consumer Assessment of Healthcare Providers and Systems. The third is the Healthcare Effectiveness Data and Information Set, otherwise known as HEDIS. So these are quality of care measures that are maintained by NCQA. The fourth is the All Payer Claims Database. So these are all claims paid by third-party payers, which are made up of the majority of health plans, Medicaid, Medicare Advantage, and third-party administrators, in addition to pharmacy benefit managers. And the last and the most recent initiative that my office oversees is the Patient Safety Surveillance and Improvement Program, which is a reporting mechanism that captures adverse patient safety events due to healthcare delivery and administration of anesthesia or sedation. So just to start off with the impact of partnerships in NYC and the local experience, as I mentioned, in 2017, I was awarded the RWJF Systems for Action grant for a project called Partnerships to Encourage Actionable Cultures of Health, known as PEACH for short. And the purpose of this study was to provide new evidence on how aligning a city health department with cross-sector community stakeholders under a place-based model can improve health and reduce inequities across neighborhoods. Our goal was to evaluate this system on the neighborhood and to specify how this alignment could be scaled up in the city and also replicated in other cities across the US. And at the core of the study was the East Harlem Neighborhood Health Action Center. The city operates operated back then, three neighborhood health action centers, one in Brownsville, Brooklyn, one in East Tremont in the Bronx, but the East Harlem one was the one that was at the core of the study. And we really drew our inspiration for pursuing this project because of the culture of health framework from RWJ, which kind of took steps to defining how we can achieve population health and well-being and equity overall. And when we saw action area number 2, fostering cross-sector collaboration to improve well-being, we sat back and noticed, it was an aha moment where we noticed that the core of the work occurring at the Neighborhood Health Action Center in New York City was just that, fostering cross-sector collaboration to improve health and well-being. So if you can imagine a large building in New York City in East Harlem with multi-sector stakeholders within it, and a building that provided clinical services, also provided programming for children, public health programming, assisted New Yorkers with getting a city ID, with signing up for benefits. That's essentially what the Health Action Center was all about. So we've had lots of community-based organizations that were co-located within this building, as well as public health programs like the Harlem Health Advocacy Partners Program, the Asthma Center of Excellence, the Newborn Home Visiting Program, Fresh Food Box, which is where fresh fruits and vegetables were distributed. You can do an exercise class through Shape Up, participate in the walking trail. The Family Wellness Suite was a suite that provided education to new moms. They distributed car seats and pack and plays and provided safe sleep education as well. And to kind of tie this all together was this system called NowPow, which was a resource directory and referral management system. And the intention behind NowPow was to close the referral loop. So if you can envision that building kind of encapsulating all of these wonderful things with the intention of improving neighborhood health, that's exactly what this was. And at the core of, and in light of the theme today, each of these neighborhood health action centers, and the one in East Harlem has a governance council. The governance council is essentially representation from each of these co-located partners, as they were called, or representatives from each of these organizations that I discussed in the previous slide. And their purpose was to support coordination of services and planning at the building level. And it was really nice to see, because when you put these organizations together, they talk about events that are happening, they cross-promote, they cross-volunteer. So there was a lot of engagement going on within the building that also emanated outside into the neighborhood. That was evident in the block parties that we saw and the health fairs and all the wonderful things that happened in East Harlem. For our study in particular, it was mixed methods. So semi-structured interviews with these governance councils was part of it. There was also visitor satisfaction surveys. There was analysis of secondary data sources, monitoring health outcomes across the neighborhood as well. But for the governance council interviews, when the representatives of the governance council were asked what the purpose of the governance council was all about at baseline, some of the things that came up was to promote transparency, to support cohesion, to address building issues, and also for strategic planning purposes. So it's transitioning over from kind of the community and voluntary nature of the group that we observed in New York. Now I'm going to talk about a statutorily mandated committee. So this is the state experience. In Utah, there is a part of our statute called 2633A, otherwise called 33A for short. It's the Utah Health Data Authority Act. So it actually creates my position within the Office of Healthcare Statistics, and it also creates the Utah Health Data Committee, which is meant to kind of steer the direction of the Office of Healthcare Statistics. So they essentially support health improvement initiatives through the collection, analysis, and public release of healthcare information, and is meant to be a public-private collaboration. So they actively participate in the planning, the development, and the implementation of the system that we have for data collection and reporting, while keeping the sectors that they're representing in mind as well, and also Utahns in general. And the Health Data Committee, we're required to maintain a committee of 15 members that have experience with health data and that represent various perspectives. So we have public health representatives, we have purchasers and payers, providers, we have associations. So within this group, we have Intermountain Healthcare, which is one of the largest healthcare systems in Utah. We've got Cambia Blue Cross Blue Shield representative, a designee from the Utah Medical Association, Molina Health Plan, AARP is also represented, just to give you a sense of the cross sector representation within the Health Data Committee. And in order to drive our statutory requirements forward, the HDC has several subcommittees. It has 5 at the moment. We've got the Executive Committee, the Transparency Advisory Group. We've got a subcommittee for facilities, for payers, and also the Data Use Subcommittee, which reviews and approves data requests on behalf of the Health Data Committee. And just to share some of the recent work of the Office of Healthcare Statistics that was informed and shaped by all of the support that's received through this statutorily mandated Health Data Committee and the derivative subcommittees, we've been able to calculate wasteful healthcare spending in Utah. That's a current project that's in statute. We've got to do it. We've looked at flu vaccination trends, COVID-19 related healthcare trends, and how healthcare kind of shifted a little bit during the pandemic. We looked at the varying costs of colonoscopy and cataract surgeries across the state, induced deliveries by race and rurality. We've calculated the proportion of total healthcare spend that is attributed to just primary care in the state of Utah. So we've been able to contribute the Utah story to that research. Also looking at emergency department visits for migraine across the state by rurality. We've identified the top drivers of ED visits for people with autism, and many, many more reports that were statutorily mandated and also not. But the common thread is that they were informed and shaped by this multi-stakeholder Health Data Committee and the subcommittees as well. And lastly, I'll talk about my experience at the federal level. This is actually a really quick one. I did a short fellowship at NIH, working specifically on the National Drug and Alcohol Facts Week initiative in 2013. And at the time, they had a lot of engagement from schools across the country, middle and high schools usually. And I came with the idea, I brought the idea to the table, why not engage colleges and universities? Because they have student clubs and organizations, they have different majors that might be interested in this. And my idea got shot down initially, but since I was a temp, I went ahead and did it anyway, right? What was holding me back? So very simply, what I did is I looked at the student clubs and organizations across the major universities across the entire country, and I created a massive outreach list. And the outcome of that outreach was an almost doubling of participation in National Drug and Alcohol Facts Week the following year. And to this day, my list is still used at NIH for outreach. But it did really give me a sense of just kind of comparing engagement and development of boards and getting community input, that the extent at the federal level, and this slide is meant to be, both a joke, but also kind of like a reality. When I think about engagement at the federal level, I feel like it's sometimes limited to forms and surveys. And it's not necessarily a bad thing. I just think that, to conclude, different agencies, whether you're local, state, or federal, they have different access and different levels of reach. So for example, when it comes to access to resources, this is just my interpretation of, this is a table I put together based on my thoughts and experiences. I think at the local level, compared to state and federal, it'll have the lowest access to resources, whereas federal has the highest, right? The federal level, they develop the NOFOs and they cut the checks. So that's just kind of a fact, I think. When it comes to access to the community and to the engagement, I think it's the opposite. Federal government has the lowest, where local level has the highest. And when it comes to access to policymakers, I'm actually still a little undecided about that. But one thing that I've noticed is that at the state level, things get done. And things get done because it's law. So I feel like when the legislature says that something has to happen, it just happens. So as is the case for us, where we've got this Health Data Committee, we've got reports that we have to put forth, and we've got to engage this group in particular. So I feel like, the access to get things done and to policymakers is a little on the high side. And just in general, working at the state level, I think that whenever I see the words policy change or influencing health policy, healthcare policy, things like that, I feel like there's something about the state level and the state legislatures that can just make it happen. And I feel like time will tell. And as I get maybe some more experience within the state, as to what that ultimately looks like when compared to local and federal levels. But there's just something about the state that, that's it's just kind of very targeted when it's in law. And that concludes this section of the presentation. I just want to thank you for your time and attention. And at this point, I will like to hand it over to Dr. Scott Hayes.
Okay, and let's see. I guess you're seeing my screen, I hope. And I'm first, I just want to say I'm glad to be here, glad to be invited. And as Glenn said, the work that we're going to present this morning stems from our public health law research program grant from a few years back. And that was actually preceded by a grant from Robert Wood Johnson Foundation as part of the SAPREAP program, the Substance Use Policy Research Program, where we looked at the adoption of smoke-free laws around the state. And that kind of led me directly to the place where one of the key factors in passing smoke-free laws, particularly at the local level, was local governments and local governance structure. And I also want to have a brief plug for my, out of that study, we also grew a youth advocacy program because the role of youth is real important for passing local laws. And that became Engaging Youth for Positive Change, which is a curriculum that we've now fully developed if people are interested in getting youth involved in local policy. But I'm here to talk about my work from the public health law research program. So I'm gonna go ahead and share my screen, and yeah, some sort of nod that you've got the screen and we're seeing it good.
We can see it. It's just not in presentation mode.
Oh, you're right. Thank you, Carrington. There you go. How's that?
Perfect. Thank you.
All right. So, okay, I'm Dr. Scott Hayes. I'm recently, as of this week or last week, Director of Research and Development with the Strategic Collaboration Group, which is a business a small business that we have formed. Last week, I was a senior research scientist at the University of Illinois at Urbana-Champaign with the Center for Prevention, Research, and Development. Just retired. I want to give you a little bit of background of what we were, where we were coming from with this work. Some of this dates back a few years, but this stuff is no less timely. We're really thinking about this new public health. I really like what Carl said about building partnerships and collaborative relationships. I mean, that's certainly where I came to this sort of work. This 2011 report from the Institute of Medicine kind of laid it out for us that state and local government should review public health laws. And the first recommendation to ensure that appropriate powers are in place to enable public health agencies to address contemporary challenges to population health, and nothing has demonstrated the importance of this any more than what's happened in the last year. So just tremendous foresight there in 2020. Nothing stronger than contemporary challenges to population health like we've all just been through. The model that they created looks like this, and we very much endorse it. I feel confident, that this is also endorsed by Carl and Glenn, that, the governing public health infrastructure should ideally link these different community partners, bringing them together. And we should, at least for the purpose of improving public health, have the public health infrastructure at the center of these particular organizations. So I really like that model also. And of course, this quote that some of you may be familiar with is that the local health departments should be the chief health strategist for their communities. So really just a great idea and a great notion that guided the work that we did. The objectives of the study we really sought to ask the question of whether, if you improved governance, can you improve community health outcomes? So if we go to the trouble to think about what a more ideal form of governance would be, what is the net effect in terms of the outcomes for health measured community-wide? Typically, that means county in most assessments of health, and certainly in our study, we were relying heavily on the data source of the county health rankings, again, provided by the Robert Wood Johnson Foundation. We also looked at the benefits and drawbacks of different health governance models, and to secure that and to try to get an idea of what's better and what's worse, although some are better in some areas and some others, as Carl just pointed out. The overall goal was that health departments increase their capacity and improve population health outcomes. This is kind of a little flow chart where we think about what is the best practice in public health governance. Hopefully this leads to increases in capacity of the local health department to integrate with their community. It facilitates policy, systems, and environmental change, also sometimes called health in all policies at the community level, that every policy that the community adopts at least considers the health implications. This is kind of like in the environmental world, environmental impact statements of any new decision that they make. And if we follow this to the end, we get healthier communities, which is what RWJ and most of the work that all of us here do is all about. So our study, what I'm going to present today is two phases of this study. And in phase one, we just drew a sample of county health departments across the country. The idea was we were drawing nationwide, but we weren't trying to take a random sample. We were using a most different systems design. So we used the health rankings to create these 4 categories. So we had counties that represented each of these in the study, evenly distributed, higher health and higher socioeconomic factors, which is what you would expect if theories are true, that a lot of health outcomes are dependent on socioeconomics. And of course, if you look at the opposite end of that table, low health, low SEF, again, consistent with our theoretical understanding. Counterfactuals are the other diagonal here. What about those communities that are lower in health and yet higher in socioeconomic factors, and higher in health and yet lower in socioeconomic factors? So we made sure and had representative of all of these categories. We ended up picking 164 counties and made sure that these counties were matched with the jurisdictions of the local health departments, which means that some states, particularly the ones listed below, are where that was just less feasible because of the nature of the way public health governance is structured in those states. We coded the relationship between the states and the localities. So again, Carl gave me a great little precursor. Although if you look at our 3 levels over here, we're not local, state, federal. We're local board of health. So does the local board empowered? Is the county empowered? So in other words, the governance at the county level empowered to deliver health services, or the state? So this is just one example in this cell, and this indicates a fairly well empowered local board of health, where when we look across at least a series of 4 different powers that local health departments, or 4 different powers that we need to have to deliver public health services at the local level: hiring and firing of the administrator, the approving of budgets, typically not making the budget, making rules and setting fees. We just say, where are these located? Does the county government have authority? Does the local board have authority, or does the state have authority? And then we can create a numerical code of where that balance lies. Then we looked at what we called the Proximal Health Index. Again, we pulled these statistics from the county health rankings at the county level. We felt like this list of statistics created an index of health outcomes that would be most likely to be affected by the services of the health department directly. Again, a higher score, note down here, means a lower ranking, which means better health outcomes. So we're going to take a look at that. Here's how it broke out in terms of just how these governance structures and board authority, we were able to create a really fine 9-level characterization of governance at the local level. It's governed purely by the state. I'm not going to read through these. You can take a look at it. But these last 3 on the bottom are kind of interesting because they all represent empowerment, a fully empowered local local board of health. And then we divided that into 3 categories, where one we called a political board of health, which means people who are elected to public office serve on the local board. The second is a combination of political designees and health professionals, and an empowered board of health has a majority of health professionals. And here, by health professionals, we literally mean physicians, like medical doctors, MDs, because we found this trend in local boards to have local boards populated with these health professional type people, which again is better or worse for public health. And we can actually examine that, which we'll do in the next slide. So, so here's just an assessment of those board authority types and their mean rank on the scale of proximal health. So the takeaway of this, without explaining a lot of we ended up using Z-scores for our index, but just take a look at the red and the white. Again, the red are the worst outcomes and the green are the best outcomes. And what's in black is the is sort of mediocre. But what you see here is in these shared governance models, in other words, where the county is balanced with the state is balanced with the local, we do have pretty good outcomes, but where we have among the best outcomes are, well, actually the also very good outcomes is in the political and health professional board of health, a locally empowered board, but it has a balanced composition. We get the worst health outcomes when we have a locality governed fully by the state. And I find that to be very interesting in the context of what Glen was talking about at the outset, you know, with this current movement for states to take away power from localities and give it to the state level. I mean, the results of this work would suggest that that would be a very poor idea if we're really interested in health outcomes. And really some of the best health outcomes that we get are with these combined boards. The other thing is the bottom of this, the red one that says Health Professional Board of Health. So this essentially is a local board of health, locally empowered, but comprised of medical professionals who, you know, distinctly are not, you know, public health trained, they're medically trained, which is really fascinating to me, where you get a bunch of doctors essentially running the health department. Again, also kind of a bad idea in terms of structure based on this research. So the takeaway findings that we provide here, that the state centralized governance have poor health outcomes. We also say locally governed departments have better health outcomes. And key to what we're discussing here today, boards with balanced representation yield the best health outcomes, and boards dominated by health professionals yield poorer health outcomes. This work was essentially published in an article in Frontiers in Public Health that's still out there and accessible, even though the journal itself went belly up a while back, but you can still find that online. The second part of our study was a 2.5-year study of governance, again, across the country. We picked very similar process, 20 most different systems, counties, to represent all of the different possibilities of what a county might look like, what the governance might look like. And then we did some interviews within each of those counties, 8 to 12. Key informants from the local health department, the board of health, where there was one, the county board, and people within the community. Let's take a look at how that broke out. We literally used this 5 variable model that made sure we had counties that represented each possible combination of these 5. So from high population to low population, from state run to an empowered board of health, from high health, again, the top third in the county health outcome ratings, to the lowest third in the health outcome ratings. So really we weren't really looking for average indicators. Again, this study was not really about creating a random sample or being able to generalize to everyone, but to speak to the different structures and how these structures would tell us about public health. So again, wealth the same way, and made sure we had regional representation, West, South, Midwest, Northwest. It turns out that there is a lot of governing variations that are unique to the different regions, and certainly in political culture and cultures of health that dominate these regions, which was fascinating. So the first thing in the sum total of all of our interviews, I wanted to say this about state versus local. So there are key advantages to each level. And again, I think this is pretty consistent with Carl's findings. The state offers expertise. The state has tremendous capacity for research, has tremendous capacity for epidemiological data gathering, and money that they can provide to the local health departments through grants, which are very important to keep local health departments engaged in certain priorities that come down from the state level. This is as opposed to purely local funding, which most health departments are funded through, local property tax. And the second one, if they're integrated with their local government, that means if they have people from the county, political representation, they can work to create a better health outcomes through policy and through work with local government, especially if it's important for funding. That also helps. And the autonomous public health department, they don't have any political bosses to respond to. They can respond to local health needs based on research, evidence, and data. So again, a key benefit of an autonomous department working at the local level, they can do what they want. They're not bound. We found in the smoke-free work that a lot of health departments were explicitly told by their county bosses that they cannot do policy work and they need to stay away from adopting smoke-free restaurant and bar ordinances. And so they were restricted from that kind of policy work, and the people in the health department knew it. Here's some disadvantages. The state tends to be too distant or detached to be effective. A lot of times the dollars from the state come with strings attached, so local decision and local authority is hampered by a lot of grants. If they're integrated with their local government, it's easy for the health department to become politicized. And if there's controversial policy work, it's harder for the health department to do that. COVID being a very, very good example of how health departments were tried to be reined in by their local communities so that they couldn't require masks and couldn't require places to shut down who weren't compliant. So very important, drawback. And the autonomous departments, they really don't have any inside basis to do policy work. So this thing becomes a disadvantage also if you're disconnected from the local community. Lastly, I want to tell you the summary of this work was, we call it the 5 keys of public health governance. We feel like definitely the board should be locally empowered. We have a few quotes here that I'm probably not going to read, but you can look those over. But essentially what we're talking about is based on the studies that we did, the interviews, as well as that data that I've just presented. It really needs to be a locally empowered board of health to accomplish and integrate local perspectives and local health outcomes. The second, we focus on the idea that the local board of health sees itself as having a community-wide role. In other words, there were some boards of health that really just simply focused on operating the health department. All they did really was approve the budget, hire and fire the administrator, and that was pretty much it. They really didn't engage themselves in thinking about, do I have a community-wide role in assessing the health of the community, in assuring that our community is healthy, and in looking at the policy options in our community and how do they reinforce and support health outcomes. That's what we want to see. And that's what these quotes really reflect, the good health departments that we found with really good health outcomes. They see themselves in this way. The third is authority, that the local board of health is not just an advisory board. The advisory boards quickly get passed into irrelevance in our experience of what we found in our interviews. So the local board does have to have the authority to approve the health administrator and approve budgets, to pass laws, to look at health regulations. So, and the boards that were purely advisory, when we interviewed them, they always said, what we really need is a little more power. I mean, this idea of advisory boards of health seems to be a good idea to some people when they were first established. But again, it really creates severe limitations in terms of how these local boards can operate and how they can support the local health department in accomplishing its goals. The fourth is that the appointment to the local board should be by multiple authorities. So in most of the local boards operating where the local health department was at the county level. The county board made all the appointments, which meant that if the county board was dominated by one political party or another, politics can play a role in board appointments, which can undermine and change authority. I mean, I have tons of anecdotes about politicizing boards of health through the appointment power, where they kind of, quote, stepped out of line in the opinion of the county elected officials. So we want to see boards being appointed by, by school board has an appointment seat when other jurisdictions. And I think this becomes a key to creating a diverse board with diverse representation. And again, these quotes kind of back that up. And then finally, consistent with that model I shared at the outset, multiple sector representation. So we want this is kind of why we want that appointment power outside the county board. So they represent the health sector, the political sector, and the community, maybe even the business sector. And we don't not want physicians on the board. Most boards had a physician, but again, the results of my earlier work that we just showed reflect that if they're all physicians, that's probably detrimental. So we really want to represent the medical community, the business community, the payer, the healthcare payer community, also data and epidemiological type people, but also people in and throughout the community. I now serve as a Forest Preserve Board Commissioner in my community of Champaign County. And I'm really trying to work closely with the Board of Health and the Health Department. It really is a key goal of mine, but I think all of these working together create the best possibilities for health. Okay, I think I'm going to stop there. Wow, yeah, looking at the time, I better. Glenn?
Fantastic, thank you, Scott. So I know we are running a little short on time, so I'm gonna try to just wrap up our panel by sharing just some highlights from research around public health governance structures that we've been conducting through our Systems for Action internal intramural research program. I'm going to go through this quickly, partly because we've actually recently done an issue, a policy brief that summarizes some of these findings that we'll make available to everyone at the conclusion of the webinar. I want to make sure we preserve some time for questions. So, let's see. Hopefully, I'm sharing my screen now. So I first want to just highlight one useful resource. The Robert Wood Johnson Foundation has developed in recent years a theory of change around multi-sector system alignment that a lot of us use as part of our research in the interaction research program. This kind of theory of change is showing on this slide currently. One of the four major pillars of system alignment in this framework is shared governance. And so, again, that's based on a larger body of research and looking at governing structures, both for corporate organizations and in the public sector for public health, but also in education, looking at hospital governing boards, et cetera, that tell us that strong, to use Scott's language, empowered governance structures that have some independence, that have authority, and also have heterogeneity in expertise and experience. Those empowered governance structures can really make a difference in helping the organization achieve goals and achieve impact. And definitely encourage folks to take a look at the publication that's cited at the bottom of this slide by our colleagues at Georgia Health Policy Center, to kind of lay out this theory of change and describe in greater detail the role of shared governance structures in helping to achieve multi-sector system alignment across medical care, public health, and social services. So our work has looked specifically at governing boards and their roles in influencing public health agencies, what they do, and importantly, influencing the outcomes that public health agencies are able to achieve in terms of achieving health and economic effects in the communities that they serve. We've used, for a lot of our intramural research, a long national longitudinal survey of communities that has now been underway for more than 20 years, started way back in 1998, called the National Longitudinal Survey of Public Health Systems. In a nutshell, the survey tracks about 600 communities across the U.S., and it measures basically the strength of the multi-sector networks that exist in those communities to support implementation of nationally recommended public health activities in those communities. We're able to measure the strength of the local networks that exist there, public health agencies, medical care organizations, social service organizations, et cetera. How strong are those networks? How strongly are those organizations working together to implement core public health activities in their communities? We use that data to come up with a summary measure of the strength of the multi-sector networks that exist in these communities, and we're able then to track how those networks change over time, how they grow more or less strong in terms of the density of organizations that collaborate, and in terms of the breadth of activities that those networks are able to support. And for this talk, we're interested in understanding how local public health governance structures may affect the strength of these networks, and therefore then may affect health and important health and economic outcomes in those communities. I don't really have time to get into the analytics. We use some pretty sophisticated econometric techniques and research designs to tease out the effects of networks ultimately on health outcomes and economic outcomes of interest. This slide shows you how we measure local public health governance structures, very consistently with how Scott described his in his typology. He's empowered local boards of health. We measure whether or not a policy-making, a local board of health exists in the community that has policy-making authority. We also measure whether that board has the authority to approve the health budget, and also whether that board has influence over the ability to raise revenue through taxing and fee authorities. So these are kind of think about these indicators of empowered local boards of health that exist at the local level. And as this slide shows you, these slides are these indicators of empowered boards are are significantly predictive of the strength of the network that exists at the local level. Places with stronger boards tend to have stronger multi-sector networks that operate in these communities. We then are able to tease out the effects of these boards on important health and economic outcomes at the community level by taking advantage of both variation across the country and where these empowered boards exist, and also changes over time in communities moving from less empowered to more empowered boards. And in particular, this slide kind of summarizes the major health and economic effects that we estimate that are attributable to strong, empowered local public health governing boards. We estimate that places that have strong boards actually see about a 4% reduction in overall rates of preventable mortality in those communities over 10 years. Those boards, the presence of those boards are associated with about almost a 1.5-year reduction in the disparity in life expectancy across low-income and high-income populations in those communities. And finally, we estimate that the presence of these strong, empowered local boards are associated with lower levels of medical care spending over time, about more than 3% lower medical care expenditures in these communities over time, in communities that have these strong, empowered boards. And that, and again, we estimate that those effects of the strong empowered boards are occurring primarily through the board effects on supporting stronger multi-sector networks that exist at the local level. I'm going to stop there so that we can use our last 5 minutes to get some questions for our panelists. With that, let me see if I can stop my screen share. And we'll see if we can tackle some questions from our panelists. Again, feel free to use the Q&A box at the bottom of your screen if you've got a question you want to ask the panelists. First question that we got early on from one of our attendees asks about county level health councils that I guess that exist in New Mexico and in a number of other states as well. These are largely advisory governance structures. They're not empowered with legislative powers or regulatory powers. What do we know about the utility of these advisory types of governance structures like the health councils that exist in New Mexico? Scott or Carl, any thoughts about advisory governance structures?
I'll hop in. This is Carl. I think that just generally advisory type groups, boards, committees are fine because it does help to influence different perspectives that you might not think of, or just kind of link you with different resources or different connections that you might not initially have. So I think that in terms of being able to broaden your reach just a little bit, the advisory councils are pretty helpful in that way. But in terms of authority overall, I think that that it would have to extend a little bit beyond, beyond like an advisory council. I think that that's probably one of the limitations.
Yeah, I'll second that, and I will say the advisory boards that we have the privilege to interview, and we made sure and interviewed them. They were important. I mean, to say what I said, I might have de-emphasized that for all the reasons that Carl just said. But yes, I mean, a critical role in communities, but yes, also to limit them to that means now that you don't really have those direct connections with the community through the authority that a more empowered board might have.
Fantastic. Thank you, Carl and Scott. Another question, I think just generally asking about how we can describe in more detail how public health governance structures actually achieve an impact on health outcomes at the community level. What are the likely mechanisms through which these governance structures actually drive improvements in health outcomes at the community level? Any insights on that one?
Yeah, let me say, just because I think my answer is relatively simple in the sense that we really were looking at laws, at the passage of local ordinances that are explicitly designed to improve the health of the community. The best practice, the evidence-based laws like smoke-free, that's kind of where I came into this. And so for me, the question became almost exclusively about what is the best structure for the health department to be well positioned to work with a local city council or a county board to pass ordinances that would improve health. And so if we believe that a smoke-free ordinance, for example, requiring smoke-free restaurants and bars at the local level improves health, I'm not going to question that evidence in this study. What I'm going to say is, how do we structure our local board so that they can be best positioned to adopt these ordinances to make sure, and then we know by a logic model that there's a connection between having one of these ordinances in place and improving health. So that's sort of the flow from at least my theoretical perspective.
Fantastic. Scott, Carl, anything to add on that one?
Yeah, part of me wants to say that it depends on the health outcome, right? If it's chronic or acute, because if it's something long-term, like we're talking cancer, for instance, and you're making any sort of policy adjustments, I mean, that's something to monitor over time. And I know that, the state legislatures and the decision makers in general, they want to see numbers and they want them ASAP. So I think that has to be laid out, depending on whether it's a chronic condition or not. But I think you can always monitor the data and work, in conjunction with your, the public health authorities to get the data to be sure that, any sort of decisions that are made at one point in time do have an influence on health in general.
Fantastic. And I just like that in terms of mechanisms through which boards can have effects on health outcomes. I would add funding and partnerships. Our work has showed that empowered boards are more successful in drawing in more financial resources into the organization. And they're also effective in brokering stronger relationships with external organizations. Strengthening the network that supports the agency and supports collaborative work around health improvement. So I know we've got just about another minute, so I'm going to ask us to weigh in on questions submitted about regional governance structures. Has any research investigated regional and multi-jurisdictional governance structures and their potential role in helping to improve public health activities and public health outcomes. Maybe Scott, did your research look at these
Yeah, it was one of the categories of governance. So we had about 4 of our counties that were part of, multi-county. So that's how we interpreted that. They're part of a multi-county system. And one of the interesting things about this, we call it the hen and chick model, essentially, where in these regional structures, you had a hen county, which is like the mother hen, it's the bigger county in the region, and then a bunch of smaller counties around it. And typically what was happening, I mean, even though these smaller counties really didn't lack the capacity to go it alone, there was still a lack of resources at the local level, and they had a harder time operating at the local level because of the dominance of the hen, so to speak. But it's an essential model in some places where the resources, you really don't have the resources to spread them. But I would describe it more, at least in what we found in our study, as a governance model kind of by necessity, that still is less than ideal, because it does undermine that idea of local governance, local decisions, local health outcomes, and again, connection to the local county board or even the local city councils or governance, because these remote entities tend to undermine the ability to operate really well locally. It's the same kind of thing that happens with state centralization.
Okay. Carl, anything to add on the idea of regional governance structure?
No, nothing to add. I think Scott covered it.
Fantastic. Well, unfortunately, we're out of time. I know that we could continue this discussion, and feel free to reach out to our panelists individually for more information. And we'll also be sending out the conclusion of this webinar out to all of the registrants, the slides, as well as the resources, the policy brief, and other relevant publications based on the research we summarized today. Thank you so much to Dr. Carl Letamendi, to Dr. Scott Hayes. Thank you all for joining us, and please attend our future upcoming sessions, more research in progress from the RWJF Systems for Action Research Program. So long, everybody.
Thank you very much.
Bye. Have a great week.